So in case you are hearing any background noise, please kindly pardon me. So can you see my screen now? Study section 11, neurological disorders. Kindly mute yourself as you are entering the class. Mute yourself. Thank you. So I'll be fast through the class because I have other things to do. Okay. So this morning, someone's mic is on. Kindly mute yourself. Thank you. So this morning we'll be handling seizure disorders. Being nurses, we all know what seizure is. And at one point or the other, we have managed a patient's seizure. So we have managed patients with seizure. So we all know what seizure is. And we have also managed a patient with epilepsy or status asthmaticus. So what is seizure? So seizure is just a sudden uncontrolled electrical discharges in the brain that causes temporary abnormalities in muscle tone or movements, behavior, sensation, or state of awareness. Then I want you to know that seizure is different from epilepsy. So what is epilepsy? Epilepsy is a disorder characterized by chronic seizure activity. So when a seizure becomes chronic and it continues to occur from time to time, then we term it epilepsy. So when a seizure continues to occur from time to time, it becomes a chronic condition. And you say such a patient is having epilepsy. And this indicates brain or CNS irritation. So when there is a continuous irritation of the brain or central nervous system, then the patient will have epilepsy. So the seizure becomes a continuous thing. It occurs from time to time. And epilepsy is a lifelong episode of seizure. Now, what is status epilepticus? Sorry, somebody's mic is on. Rosemary, your mic is on. All right. Please, as you're entering the class, kindly mute your mic. Thank you. So what is status epilepticus? Status epilepticus involves a rapid succession of epileptic spasms without interval of consciousness. So this one is worse than epilepsy. So status epilepticus is that epilepsy becomes a continuous thing. So it's more like a complication of epilepsy. That is why we call it status epilepticus. So it involves a rapid succession of epileptic patients to continue to have epileptic spasm without any interval of consciousness. You know, in epilepsy, patients will have seizure, patients will have patient will regain consciousness, patients will have seizure, patient will regain consciousness. But when it becomes status epilepticus now, there is no interval of consciousness. So it is a potential complication that occur with any type of seizure. And this can result in what is known as brain damage. So I hope you are still with me. Are we still together? Okay. So as nurses, when your patient is having seizure, that is why it is important for you to time it. You know, part of our nursing intervention is when your patient is having seizure, you should time the seizure. So we are not just timing the seizure for fun. The reason why we are timing the seizure is for us to know if the patient is having epilepsy or status epilepticus. When you time your patient's seizure and it's more than 5 minutes, then you know that there is problem. This patient is having status epilepticus. So this has gone beyond, patient is just having normal seizure or epilepsy. Now, what are the causes? What are the causes? Anything that can cause brain swelling, hypoxia, can cause seizure. infection like meningitis. That is when the brain is infected, and there's infection of the meninges. When there's trauma, traumatic brain injury, concussion, then when there is brain mass, maybe brain tumor, when there is anything that increases the intracranial pressure, anything that causes increased intracranial pressure, will definitely cause seizure. Then febrile seizure in infants, when the temperature is more than 39 or 40 degrees centigrade, when the patient is having hyperpyrexia, then withdrawal from drugs and alcoholism. Now, let's quickly talk about pathophysiology of seizure. So when we are talking about seizure, we have two main things that we are supposed to have in mind. We are talking about GABA and glutamate. There are two types of neurotransmitters in the brain. We call them the GABA and the glutamate. GABA and the glutamate. The meaning of GABA is gamma aminobutyric acid. So that GABA is a neurotransmitter that it is called inhibitory neurotransmitters. We call the GABA inhibitory neurotransmitters for the CNS. So what it does is that it reduces neuronal excitability by inhibiting nerve transmission. So that is what this GABA does. While glutamate is just the opposite. Glutamate is an excitatory neurotransmitter. So immediately there is an imbalance between gamma and glutamate, then patient is likely to have seizure. So both of them must be balanced. One serves as an inhibitory neurotransmitter, while the other one is an excitatory neurotransmitter. So there must be a balance between GABA and glutamate. So immediately there is loss of balance, immediately there is no balance between them. Maybe one is higher, especially the one that it will cause excitatory action. Immediately that one is higher than the other, then there will be problem. So that is just the simple pathophysiology of seizure. Now let's go to types of seizure. What are the types of seizure we have? We have two major classifications. We have the generalized and the partial. So under each type now, we now have subdivisions. So under generalized seizure, when you hear the word generalized, that means it affects all the parts of the brain. The generalized seizure affects the whole parts of the brain. That is the meaning. So under it now, we now have subdivisions. And I want you to take note of those subdivisions. The first one is tonic-clonic, also known as grandma seizure. So what do we mean by tonic-clonic? Tonic-clonic seizures begin with an aura. Then the tonic phase involves, so in the tonic phase, there will be stiffening and rigidity of the muscles of the hands and legs. Everything will be stiffened. Thank God we have all managed a patient with seizure. We all know the way a patient with seizure, we all know the way they present. So there will be stiffening and rigidity of the muscles, of the arms, of the legs. Everything will be stiffened at that particular time. And this lasts about 10 to 20 seconds. And it will be followed by loss of consciousness for the tonic phase. Now the clonic phase consists of hyperventilation. When the patient moves to the tonic phase, there will be hyperventilation, there is recurrent jacking. So at this phase, there is no longer stiffening. There's no longer rigidity at this particular point. So patient will begin to hyperventilate, patient will begin to jack, and this lasts for about 30 seconds. And full recovery from this seizure may take several hours. Then another one we have under generalized is absent seizure. We call it tetisma. This absent seizure is usually very common in the children. So you see, like maybe if you have a child on admission, or if you see a child that's having absent seizure, the child might just be looking at a particular direction. It will be as if the child is daydreaming at that particular time. So it is very common in children, and this type of seizure goes unnoticed, and it lasts few seconds. In fact, sometimes if you are not careful, you might not even notice it. So a lot of children suffer from this absent seizure. So sometimes the child might just appear to be daydreaming. They will just lose, they might not lose consciousness, but it just goes for a few seconds. And there's no loss or change in muscle tone. There's no loss, no change in muscle tone. So that is why it is not that obvious that the child is having seizure. That is why we call it absent seizure. So the child appears to be staring. The child might just be looking, staring at a particular direction. The child might appear to be daydreaming, just lost in thought at that particular time. Then another type, under types of seizure, is myoclonic seizure. Myoclonic seizure. Myoclonic seizure presents as a brief generalized jerking or stiffening of the extremities, and the victim may fall from the seizure. So there is muscle involvement. Then when we're talking about atonic or akinetic, another name for it is stroke attack. So in atonic or akinetic, there is sudden momentary loss of muscle tone. From the word atonic, that means there is absence of what? Muscle tone, when you hear the word atonic. So there is sudden momentary loss of muscle tone at that particular time, and victim may also fall as a result of the seizure. Now we have partial seizure. That is the second classification of seizure. So we are done with generalized seizure. So under partial seizure, this is the type of seizure that affects specific parts of the brain. Unlike the generalized seizure, that one affects the whole part of the brain, but the partial seizure affects just specific area of the brain. And we know that the part of the brain, when we're talking about in the last lecture, I told you that different types of the different parts of the brain has different functions. So it depends on the part of the brain that's affected. That will depend, that will determine the signs and symptoms that the patient is going to present with. So this one affects just the specific areas of the brain. And under it, we have the simple partial. The first type is simple partial. So the simple partial seizure produces sensory symptoms accompanied by motor symptoms. So under simple partial, we have sensory symptoms. The patient is going to present with motor symptoms that are localized or confined to a specific area. The client remains conscious, and the clients may report an aura. You know that most of these patients, before they go into seizure, there's something we call aura. So most of the time, the patient will just feel like most of the time the patient knows there is a kind of sensation they feel before they go into seizure. So the clients may report an aura. Then it affects the occipital region, leading to what? Vision problem. And it happens suddenly, and the patient is aware. I hope I'm making sense. So are we still together? Okay. Okay, thank you for following. So now the second type of seizure we have under partial is the complex partial. So the complex partial seizure is a psychomotor seizure. And the area of the brain most usually involved is the temporal lobe. It is the temporal lobe that is usually affected under the complex partial. There is alteration in awareness and motor symptoms. An example of these motor symptoms is automatism. So in patients that has complex partial seizure, they might experience list marking. So patient can experience list marking. You might see your patient rubbing their hands together. And sometimes your patient might be grabbing the hair. So when you see symptoms like this, you should know that, okay, this patient is having complex partial seizure. So it's combination of what? There is psychomotor, the complex partial seizure is a psychomotor seizure, and it affects the temporal lobe region. So this seizure is characterized by a period of altered behavior of which the client is not aware. The client loses consciousness for few seconds. Now, what are the things that can actually trigger seizures? What are the things that can trigger seizure? Stress, sleep deprivation, fatigue, flashing of lights. You notice that some patients that are epileptic patients, you know that sometimes when they are walking beside the road and they see flash of light or there is a sudden noise, you know, most of these patients, they go into what? Into their epileptic attack. So flashing of lights, stimulants, hypoglycemia, when the blood glucose level is low, patient can have seizure. Then hyponatremia, when the sodium level is below 135. Somebody's mic is on. Somebody's mic is on. Ishola Folashade, your mic is on. Deborah Ghana, your mic is on. Please kindly mute. So hyponatremia, as I was saying, can cause seizure. Low sodium level, when the patient, when the sodium level is below 135. Then trauma, overexertion, alcohol, under medication. When a patient is not taking their medication, they can have seizure. Now let's go to stages of seizure. What are the stages or phases of seizure? We have the prodromal phase. What happens under the prodromal phase? Patients will experience mood swing, depression, hunger, insomnia, anxiety, GI and urinary issues. And prodromal can occur without seizure, definitely. It can start days before seizure, and this can be prevented. So this prodromal phase, when the patient starts complaining that they're having mood swing, especially an epileptic patient, they're telling you that they have started experiencing insomnia, or patients start experiencing funny taste. I don't know why. Please kindly mute yourself. Check your mic and mute yourself. All right, so as I was saying, this prodromal phase can be what? It can be prevented. It can be prevented. Then aura is the second phase. Aura happens with seizure. It happens with seizure, and it happens seconds before seizure. So during this stage, patients experience like a weird smell, a weird taste. They will just feel like a weird taste. When your patient starts telling you that, okay, I'm feeling this particular type of taste, then you should start suspecting that this patient is about to have what? Seizure. Then feeling of deja vu, hearing problem, dizziness, and loss of work. So these are the signs and symptoms that comes with aura phase. Now, another thing that patients, another phase is ictus or ictus phase. So this ictus or ictus phase is the actual stage of the seizure, whereby the seizure actually happens. So the patient is now experiencing seizure at this particular time, and it can last for about 1 to 3 minutes. So at this stage, what are you expected to do as a nurse? You're expected to time the seizure. And this is why I told you earlier on that when you time your seizure, it shouldn't be more than 5 minutes. Any seizure that is greater than 5 minutes will be termed as status epilepticus, because it is very detrimental to the health of the patient. So that is why it is important for you to time the seizure. So the seizure must not be more than what? 5 minutes. Then the last phase is the post-ictal or the recovery phase. So at this particular phase, the seizure has come to an end. There is no more seizure at this particular time. The patient returns to baseline. Then it takes hours to days before patient recovers. Then patients feel tired at this particular stage. Patients can be confused. They might complain of headache. Then at this time, you might see that patient has actually what? They have actually urinated on their body. There might be injury to the tongue during the course of the seizure. The patient might have bitten their tongues at that particular time. There's injury to the cheek and the body. Patients might have injured themselves. So at this particular time, during the stage of seizure, during the itra phase or the itus phase, it is very important as nurses for you to maintain safety. It is very important for you to what? Maintain safety. So it is very important for you to maintain safety during the itra phase because you don't want your patient to injure themselves. You don't want to put anything in your patient's mouth. You want to remove anything around the patient, around the environment that can actually injure your patient. The patient is unconscious during the itus phase. The patient doesn't know what is going on. If there is fire, the patient can fall into the fire at that particular time. The patient can be drowned. So that is why at the itus phase, it is very important for you as nurses to maintain safety. You don't want your patient to hit their head on anything. You want to remove anything. You want to pad the side rails. Because if the patient is experiencing seizure on the bed and the side rails are up, you want to lift up the side because definitely you don't want your patient to fall or you want to put your bed at a very low level. So this is why it is very important for you as a nurse to maintain safety because you don't want your patient to experience any form of injury. Now, how can you diagnose seizure? What are the things that can be used as a diagnostic measures? The first thing is MRI. Patients can also do CT scan to look for abnormalities. Can do CT scan to look for abnormalities within the brain. Electroencephalography can also be done. This assesses electrical activity in the brain. So when they order electroencephalography, it's just to assess electrical activity in the brain by placing sticky electrodes on the scalp. Now, I want you to take notes. What are your nursing interventions where your patient is going for EEG? What are the nursing interventions that are expected of you? The first thing you should do as a nurse is to wash the hair. You want to wash hair before and after to make sure that it sticks. They will place the electrode on the scalp. So you have to wash the patient's hair. You ensure that your patient does not take any form of caffeine or stimulants 12 to 24 hours before the procedure. No form of seizure medication. You don't want to give your patient, this patient is having seizure and want to diagnose, want to actually know why this patient is having seizure. So you don't want to give any form of seizure medication because if you give seizure medication, definitely it is going to alter the results. It is going to alter the results. So we are not going to find anything. Everything will be normal at that particular time. Then sleep deprivation is also the best. You want your patient to remain awake prior to the procedure. You don't want your patient to sleep. So you have to make sure that patient is deprived of sleep prior to the procedure. Then there is no need to put your patient on MPO. There is no need for you to put your patient on MPO. Patient can be on, patient doesn't need to be on nail pahora. Patient does not need to be on nail pahora. Now, what are your nursing interventions? I wouldn't stay long on this because we all know our nursing intervention when it comes to what a patient with seizure. You should assess your risk factor, seizure precaution. I think I've mentioned some when I was talking about the icta phase now. Make sure the bed rails are padded. Want to put your bed in the lowest position. Assess seizure history. During the procedure, put the patient on side because you don't want your patient to aspirate. Patient is not conscious. Patient doesn't have any control over that moment. Should not restrain your patient. Do not put anything in their mouth. If there is any restrictive clothing, patient is putting on any glasses, you have to remove it. Then you time the seizure, know the characteristics of the seizure. Then once the patient comes around, you reassure them, calm them down, check their vitals, note their behavior, give them their medications, draw blood sample. Now let's go to medication. So what are the medications that we can use in the management of seizure? What are the medications that we can use? The first group of medication is barbiturates. First group of medication is barbiturates, like phenobarbital, which is used for what? Tonic, clonic, or focal seizure. It can also be used for status epilepticus. Somebody is already writing on my screen. Please be mindful. Be mindful of what we are doing. Please don't write on my screen. Be mindful of your phone. It might be a mistake. Okay, so let's continue. So barbiturates is the first group of medication that can be used to treat seizure. So it works by stimulating GABA receptors, and this helps inhibitory neurotransmitter. I told you when I was talking about the pathology that imbalance between GABA and glutamate will make a patient to have what? To have seizure. So I hope we are still together. So can you just type, are we still together? Can you still hear me? All right, okay. So I told you that imbalance between gamma and glutamate will lead to seizure. So what barbiturate will do is that it works by stimulating GABA receptors. And this helps the inhibitory neurotransmitter. Then what are the side effects of barbiturates? You all know ataxia and drowsiness. Then you monitor the patient for respiratory depression. Monitor the patient for respiratory depression and hypotension. We all know that barbiturates can lead to what? It can depress the respiratory center and it can lower the blood pressure. So you have to monitor for respiratory depression and hypotension. Then know the therapeutic level. The therapeutic level of barbiturates, of phenobarbital is 15 to 40 microgram per ml. 15 to 40 microgram per ml. Now, the second group of medication is idatons. Example is phenytoin. So phenytoin is also used for partial or generalized tonic-clonic seizure. And the major side effect of phenytoin is gingival hyperplasia. Gingival hyperplasia, there will be swelling of the gum. So when patients with epilepsy are on this particular phenytoin, especially for a long period of time, you notice that one of the major side effects is this gingival hyperplasia. So their gum will be excessively swollen, and any little damage, or how would I put it now, any little damage to that gum will lead to bleeding at that particular time. You know, everything at that particular time, the gum is so fragile. So the gum will be swollen up. It's so fragile at that particular time. So you want to tell your patients when they're on phenytoin that they should not use hard brush. They should not use hard brush. When they are on phenytoin, they shouldn't use hard brush because it will definitely lead to what? Bleeding, gum bleeding, because the gum is already fragile, swelling up at that particular time. Then another thing they suffer is bone marrow suppression. So they are at risk for what? Infection when they are on this particular phenytoin. Another side effect is Stevens-Johnson syndrome. So you have to monitor them for rash. If there's any form of unusual rash, if your patient is on phenytoin and they're having any form of unusual rash on their body, then you should start suspecting Stevens-Johnson syndrome. And this Stevens-Johnson syndrome is a very dangerous form of rash. So you don't want to joke with it. Then they are prone to what? Having nystagmus, headache, and slurred speech. So these are the major side effects of phenytoin. So you monitor for rash. You want to monitor their platelets and WBC because of what? There is bone marrow suppression. Then when a patient is on phenytoin, do not give antacids. Do not give antacids. When a patient is on tube, you don't want to give it together with tube feeding or milk. These are the things that will affect what? The potency of this medication. Then no flossing. I've talked about that. No using of hard brush. When a patient is on phenytoin, tell them not to use hard brush because they are prone to what? Having gingival hyperplasia. There is no flossing. Then you have to tell them to maintain good oral what? Oral care. They have to maintain high level of oral care. Then the therapeutic level for phenytoin is 10 to 20 microgram per mil. 10 to 20 microgram per mil. So that is why it is important for you to monitor the blood level of this particular medication. Very, very important. So as nurses, we are supposed to know the therapeutic level of this medication. Sorry, just a moment. Now, another medication we can use is benzodiazepines. Benzodiazepines. So example is diazepam or lorazepam. So sorry for the distraction. So another group of medication we can use is benzodiazepines, which is either diazepam or lorazepam. And it is used majorly for what? Status epilepticus and absence seizure. So it is fast acting for status epilepticus. So when you notice that your patient is having status epilepticus, you can give diazepam because it is what? It is fast acting. Then side effects include drowsiness, dizziness, blood dyscrasia, and what? Liver impairment. So it is hepatotoxic. So have it at the back of your mind that diazepam is a what? It is hepatotoxic. So when a patient is on this diazepam, you have to monitor what? Their liver enzyme. Then the reversal agent for benzodiazepine is flumazenil. It is flumazenil. It is the reversal agent that you can use for what? Diazepam. Please, I hope I am making sense. Any questions so far? No sound. Please, can you hear me? Some people are saying no sound. Please, can you hear me? Okay, thank you. Okay. Now, another group of medication that we can use is valproate, which is valproic acid. So this valproic acid can be used for all types of seizure. Can use it for all types of seizure. And what are the major side effects? Another major side effect is blood dysplasia, GI issues, hepatotoxicity. So when a patient is on valproic acid, you have to monitor the platelets and the WBC. You have to monitor the platelet and the WBC at that particular time because of the blood dysplasia. That is the major reason why you are monitoring the blood platelets and WBC. So because this drug has the tendency to reduce the number of what? White blood cells and platelets. So there will be drastic reduction in the number of platelets and the WBC. So you have to monitor for liver enzymes. Are the liver enzymes, are they within the normal range? So that you know whether your patient's liver is going into failure or not. You monitor the amylase level. Amylase level is also very important because it causes what? Pancreatitis. So you have to monitor the patient's amylase level. It is contraindicated in pregnancy. And never discontinue this medication, any form of anti-seizure medication, never discontinue them abruptly. Because it can cause what? It can cause mood changes. So when you want to discontinue anti-seizure medication, you don't discontinue it. It's like you wean the patient off gradually. So you don't discontinue it abruptly. So any questions so far on seizure? So when any questions so far on seizure before we move to okay, someone has posted the meaning of blood dysplasia. Yeah, okay, thank you for that. Any questions so far? Can we move to myasthenia gravis now? Which should be the last topic for the day. Any questions so far? Meaning of BACA. I didn't mention anything like that. BACA. No. Can you rephrase your question, please? I didn't mention anything like that. Gamma. Gamma aminobutyric acid. It is a neurotransmitter. You are in 400 level. You shouldn't be asking me the meaning of gamma, please. Okay. Sure. No different types of neurotransmitters that we have. So, any form of question, can we continue? Now, all these medications that we use for treatment of seizure, it is very important for you to, I was telling you about the therapeutic level. Why should you know the therapeutic level as a nurse? The reason why you should know the therapeutic level is for you to be able to monitor the peak and trough. Well, unfortunately, I'm not sure if you do that here in our Nigerian hospitals. I'm not sure if we nurses do that, but I'm sure the doctor should be doing that. We should be monitoring the peak and trough. When you're talking about the peak means when the drug is at the highest, it's at its highest level in the blood. You know, all the medications we give, you know, they have their peak, they have their trough. So we are knowing the therapeutic level. I want you to know the therapeutic level as a nurse because so that you'll be able to monitor the peak and trough of this patient. You want to, of these particular medications in the blood, when these medications are at its peak in the blood, you wouldn't want to give your patient another medication at that particular time. But I know that in the developed country, they monitor the peak and trough of all these key medications. Because when the peak is at the highest level, when this medication is at its peak, you would not want to give your patient another medication at that time. And when it's at its trough, lowest level, you know that, okay, it's time for you to give this patient medication. So all these medications, you don't just administer them to the patient without knowing their peak and trough. So that is why it is important for us to know the therapeutic level. So I hope I'm making sense, please. Okay, so let's move to myasthenia gravis. Myasthenia gravis. Okay, so what do we mean by myasthenia gravis? It's also a neurological disorder. And myasthenia gravis is an autoimmune disease whereby the body attacks the acetylcholine receptors. So the body attacks the acetylcholine receptors. In a patient with myasthenia gravis, the problem we have is acetylcholine. So when a patient has myasthenia gravis, there is low level of acetylcholine. So in a patient with myasthenia gravis, the acetylcholine receptors has been what? It has been affected. So it is an autoimmune disorder. So you find out that the antibodies has affected the acetylcholine receptors. And as a result, these receptors will not be able to pick up what? They will not be able to pick up enough acetylcholine from the neuromuscular junctions. I don't know if I'm making sense. So I'm taking my time to explain so that we will know the pathology behind it. So there is problem with the acetylcholine receptors. They will not be able to pick up enough acetylcholine at the neuromuscular junction, and there will be low level of acetylcholine, and it will result in severe what? Muscle weakness. That is just the simple pathophysiology. So autoimmune disease of the neuromuscular junction is characterized by fluctuating weakness of certain muscle groups. So acetylcholine is very important for muscle strength. We need acetylcholine in our body to for maximum strength of it. We know we have different types of muscles. We have the muscles that we use for respiration. We have the muscles that we use for walking. We have different types of muscles for mastication, for chewing, a lot of things. But when in a patient with myasthenia gravis, there is weakness of most of these muscles because of what? Low level of acetylcholine. Now look at this diagram. Can you see this diagram on my screen? Can you see this diagram on my screen? I just want to use diagram to explain that simple pathology of myasthenia gravis. Please kindly respond. Can you see this diagram? So this diagram will simplify it for us. Now, on this particular slide now, on this particular slide, you can see so it has already been labeled. We see acetylcholine. There are small, like a circle. Small, you can see like small cubes, or let me say circle now, that are in blue color. Those are the acetylcholine. You can see that they are being released. You can see where they are being released from. They are released. This is the neuromuscular junction. Abdul Salam, please don't write on my screen. You can see the acetylcholine, they are being released into the neuromuscular junction. They are being released into the neuromuscular junction. Now, on the, you will see another thing I labeled as acetylcholine receptors. They are in purple colors. Acetylcholine receptors. Those are the acetylcholine receptors. So these acetylcholine receptors are the one that will be picking up the acetylcholine that is being received, which will be used by the muscle. Now, the acetylcholine receptors are now being affected or attacked by antibodies. You will see another thing that is labeled as what? Antibodies. So these antibodies, what they do is that they will attack the acetylcholine receptors. And these acetylcholine receptors will not be able to pick up the acetylcholine that are being released from the neurons. Can you see? They will not be able to pick it up. So I think the acetylcholine is in brown color. So they begin, that's antibodies are in color brown. So they are the one that will be affecting the acetylcholine receptors, and it will not be able to pick up the acetylcholine. So when they are not able to pick up the acetylcholine, the muscles will what? The muscle needs what? They need acetylcholine for strength. So as a result of that, these patients will experience what is known as severe muscle weakness. Please, are you getting what I'm saying? Please, am I making sense? Okay. I need more response, please. Thank you. So it's as simple as that. So we need acetylcholine at the neuromuscular junction. The acetylcholine receptors need to pick up the acetylcholine for the muscle to function. Once these receptors are affected by the antibodies, you can see the antibodies are in color brown. So it is just, this is not, this is just like a pictorial representation for us to be able to understand. So once these antibodies start affecting the acetylcholine, and the acetylcholine receptors, they will not be able to pick it up for the muscle to function. So that is just a simple pathophysiology. So what are the signs and symptoms? I told you that patient is experiencing of severe muscle weakness. There are different groups of muscles in the body that will be affected. There will be weakness of the neck, face, arms, legs. There will be ptosis. There will be muscular facial expression. Like what we're talking about Parkinsonism too. You know, patient has a muscular facial expression. Patient choke when eating. And why do they experience choking? Why do they experience choking? Well, no, there is muscle. We know we need muscle to masticate. We need muscle to chew. These patients cannot do all this. All the muscles are weak. So this patient will experience choking. There will be loss of they will have no energy. There will be loss of strength. The extraocular muscles will also be affected. So this patient will have strabismus, double vision, diplopia, ptosis, slow speech, shortness of breath, and restlessness. Then, what are the complications of myasthenia gravis? There are two major complications. There are two major complications, and these complications can occur as a result of maybe too much level of acetylcholine or low level of acetylcholine. Now, let me explain. A patient with myasthenia gravis can either experience myasthenic crisis or cholinergic crisis. Now, let me explain what I mean by that. Because I want you to take note. Those are the two major complications that a patient with myasthenia gravis can experience. I told you that myasthenia gravis occurs as a result of what? Low level of acetylcholine. Occurs as a result of low level of what? Acetylcholine. Now, definitely, when you want to treat a patient with myasthenia gravis, so you all know that, okay, the problem is acetylcholine. We know that, okay, this patient is having low levels of acetylcholine. So definitely, we know that we are supposed to give more acetylcholine to the patient. This patient does not have enough acetylcholine. So whatever we are going to give to the patient, it has to be what? Acetylcholine. This patient needs acetylcholine. Now, this patient, I told you that I said this patient can experience either myasthenic crisis or myasthenia or cholinergic crisis. Now, for myasthenic crisis, disease can go into remission, but can experience acute exacerbation. There will be severe muscle weakness, which will lead to what? Respiratory failure. So in myasthenic crisis, that means patient is experiencing severely low level of what? Acetylcholine. So in myasthenic crisis, patient is experiencing a very low level of acetylcholine. And the funniest thing is that when the patient is having myasthenic crisis or cholinergic crisis, they will both experience the same signs and symptoms. So when your patient comes or presents to the hospital, how do you now diagnose if the patient is having myasthenic crisis or cholinergic crisis? How do you now know it? How will you know it? Because when the patient is having low level or severely low level of acetylcholine or too much level, when the acetylcholine is high or is low, they will both present with the same signs and symptoms. Now, what are the things that can cause this myasthenic crisis? When there is no enough acetylcholine, or when a patient is not receiving enough anticholinesterase medication, stress, respiratory infection, and surgery. Please, am I making sense? Am I making sense? Am I making sense? Okay. So when the patient is not having enough acetylcholine, or the patient with myasthenia gravis is not taking enough anticholinesterase medication, definitely what they will use to treat a patient with myasthenia gravis is anticholinesterase medication. Now, when I was talking about pathophysiology, I did not talk about cholinesterase. There's something we call cholinesterase. So it is this cholinesterase. Any word you hear, or any words that you see that it has ASE, then we should know that it is an enzyme. So this cholinesterase is an enzyme. So what this cholinesterase does is that it breaks down neurotransmitters. When neurotransmitters are released into the neuromuscular junction, you know, the muscles, the body picks up the ones they need. Now, what will happen to the remaining neurotransmitters at the neuromuscular junction? It is this cholinesterase that will do what? That will break them down. It will break them down. It will break down the remaining neurotransmitters that we don't need. No, so now in a patient with myasthenia gravis, we are going to give them anticholinesterase medication. And what do they do? They antagonize the what? The action of cholinesterase, so that they will not break down the neurotransmitters. You know that in a patient with myasthenia gravis, there is low level of acetylcholine. So we want to have enough acetylcholine at the neuromuscular junction. So we don't want this cholinesterase. So the reason why they give anticholinesterase is that we don't want this cholinesterase to break down the acetylcholine we have at the neuromuscular junction. So when the patient does not receive enough anticholinesterase medication, they are prone to having what? Myasthenic crisis. So another complication is what? Cholinergic crisis. Another complication is cholinergic crisis. So definitely cholinergic crisis is the opposite of what? Myasthenic crisis. So in cholinergic crisis, that means patient is having too much of acetylcholine. You have been giving your patient too much of what? Anticholinesterase medication. So this brings about excess acetylcholine at the neuromuscular junction, leading to what? Severe muscle weakness. So when a patient has what? Myasthenic crisis or myasthenic or cholinergic crisis, they are going to present with the same signs as symptoms. Now let's talk about diagnosis of myasthenic gravis. Myasthenic gravis. How can we diagnose it? Now, I told you that when a patient has myasthenic gravis, or when they have cholinergic or myasthenic crisis, they are going to present with the same signs and symptoms, although the severity will differ. So now, how can you diagnose? What are the things how can you diagnose if a patient is having what? Myasthenic gravis, myasthenic crisis, or cholinergic crisis? They are both, all of them are presenting with what? The same signs and symptoms. So there is something they will do to know the exact problem this patient is having, to know if the patient is having too much level of acetylcholine or low level of acetylcholine. So what they will do is that there's something we call tensilon test. So this tensilon test, eldrophonium will be administered to this patient. This eldrophonium is an anticholinesterase. I told you that anticholinesterase breaks down cholinesterase at the what? At the neuromuscular junction, so that this cholinesterase will not go and break down all the neurotransmitters that we have at the neuromuscular junction. So this eldrophonium is a form of what? Cholinesterase inhibitor. So this is this eldrophonium that will be administered to the patient. So when they now administer this eldrophonium to the patient, if the patient's symptoms improve, definitely you know that this patient is what? Having myasthenic crisis. But if the patient's symptoms worsen, then you'll be able to know that, oh, this patient is having cholinergic crisis. Does that make any sense? What I just explained now, does it make any sense? Does it make any sense? Okay, someone said I should come again. Okay, it doesn't make any sense. Okay, thank you. Now, what I'm trying to say is that I told you that patients with myasthenic gravis have problem with what? They have problem with acetylcholine. There is low level of acetylcholine. I told you that antibodies affect what? They affect the acetylcholine receptors. Someone is drawing on my screen. Please be careful. Be careful the way you handle your phone or whatever. So when I told you that patient with myasthenia gravis, they have problem with acetylcholine. They have problems. And I told you that acetylcholine is necessary for what? It is necessary for muscle strength. We have different groups of muscles within the body that perform different functions. So when these muscles doesn't have enough acetylcholine, they don't have access to enough acetylcholine, they will be what? They will experience severe muscle. There will be muscle weakness. These muscles will go into weakness. They will lose strength. They will not be able to function properly. So now, when patients with myasthenia gravis can either have two complications. They can either have myasthenic crisis or cholinergic crisis. Myasthenic crisis means there is the level of acetylcholine is too low. It's too low. Then when they are having cholinergic crisis, that means the level of acetylcholine is too high. And I told you that funny enough, when a patient has maybe when the acetylcholine level is either too low or too high, this patient are going to present with the same signs and symptoms. You cannot differentiate. When a patient presents with myasthenia gravis, they present with a cholinergic crisis or myasthenic crisis. They are going to present with the same signs and symptoms. Now, how do you want to differentiate? How do you want to differentiate? How do you want to know if your patient is having myasthenic crisis, myasthenic gravis, or cholinergic crisis? You cannot differentiate because they are both, all the three of them are presenting with the same signs and symptoms. So it is this tensilon test that will help you to differentiate. So now in tensilon test, what you are going to do is that you are going to administer what is known as hydrophonium to your patient. This is what the doctors do to be able to diagnose a patient with myasthenia gravis. Now, when they see that, okay, this patient is presenting with all these funny signs and symptoms, they want to know what is wrong. So they will administer what is known as hydrophonium. And I said that hydrophonium is an anticholinesterase, or you can either call it cholinesterase inhibitor. From the word cholinesterase inhibitor, that means cholinesterase inhibitor is inhibiting the work of what? Cholinesterase. When you hear any word with ASE, that means it is an enzyme. Cholinesterase is an enzyme that breaks down what? The remaining neurotransmitters. That breaks down the remaining neurotransmitters. Some people are still writing on my screen. I do not understand. Please, you are distracting the class. Now, it is this cholinesterase that breaks down the remaining neurotransmitters at the neuromuscular junction. When neurotransmitters are released, dopamine, whatever, acetylcholine, when they are released, the body will pick up the ones that is needed. And the remaining one will not just be there. The remaining ones will be broken down by cholinesterase. So that is the work of that cholinesterase. Now we are going to give this patient anticholinesterase. And the name of this anticholinesterase is hydrophonium. So when you give this patient anticholinesterase and you see that their symptoms improve, that means that patient is having myasthenic crisis. Because what anticholinesterase will do is that it will prevent what? Cholinesterase from breaking down the remaining acetylcholine we have at the neuromuscular junction. You know that patients with myasthenia gravis are suffering from low level of acetylcholine. So the little acetylcholine we have at the neuromuscular junction, we wouldn't want any cholinesterase to come and break it down for us. We don't want that cholinesterase to destroy it because this patient is suffering from low level of acetylcholine. Now, you want to give a medication that will make sure that, okay, the cholinesterase is not breaking down those acetylcholine. So that is why we are giving hydrophonium. So when you give this hydrophonium and this patient verbalizes improved symptoms, then you will know that this patient is having what? Myasthenic crisis. Because immediately you give that hydrophonium, the patient's symptoms will improve. You will see that the muscles that lack strength will begin to have strength. But when you give them this anticholinesterase and the patient's symptoms worsen, or the patient begins to complain that, oh, these symptoms is getting worse and worse, then you know that, oh, this patient is having cholinergic crisis. I hope I should be making sense now. Because when you give a patient that is having low level of acetylcholine, you are giving them, that is having too much level of acetylcholine, you now give them anticholinesterase. That means there will be more acetylcholine again at the neuromuscular junction, more than the one that the body requires. And this patient will go into what? Into a severe muscle weakness. So I hope I'm making sense now. Now, in case the patient is now having cholinergic crisis, in case the patient is now having cholinergic crisis, which is too much of acetylcholine, now, what will you do? You have already given hydrophonium to your patient. Then definitely you are going to have an antidote. You're going to have an what? You're going to have an antidote. And what is the antidote that you're going to give to your patient? Atropine. Atropine gives what? Atropine produces anticholinergic effects. So you don't want to give this patient hydrophonium and just be looking at them. You have given this patient hydrophonium and this patient's symptoms has worsened already. So definitely you have to give something. Definitely you have already diagnosed that, oh, this patient doesn't need much acetylcholine. This patient has already have too much level of acetylcholine. This patient is having cholinergic crisis. So you can't just be looking at your patient. So definitely you are going to give antidote. And that antidote is what? Atropine. And we all know that atropine is an anticholinergic. I told you when we were talking about the sympathetic nervous system and the parasympathetic nervous system, that the anticholinergic is found in the what? In the sympathetic nervous system. So you're going to give antidotes, which is atropine, to counteract the effect of the hydrophonium you have already given to the patient, because their symptoms has been worsening. I hope this now makes sense to you. So that will be all about penicillin test. So what are the nursing interventions? What are the nursing interventions? Since we all know the signs and symptoms, you have to monitor respiratory status, monitor the ability to cough and deep breathing. You know, this patient, the muscles of the respiration are affected. So this patient is likely to what? To have respiratory problem. Monitor for respiratory failure, maintain functioning and emergency equipment at the bedside, monitor vital signs, monitor for speech and swallowing abilities to prevent aspiration. Encourage the client to sit up when eating, because you don't want them to choke. Assess the muscle status. Instruct the client to conserve their strength. You know, these patients are not having enough strength. Tell them to conserve their strength. Plan short activities that concern with times of maximum stress. So all the activities this patient is going to indulge in or is going to engage in, it has to be during the time that they are having their strength. All the activities must be planned maybe in the morning or when the medication, when the action of the medication is at its peak. You have to monitor your patient for myasthenic or cholinergic crisis. These patients are on anticholinesterase medication. So you have to monitor them. You don't want them to go into cholinergic crisis. You want them to go into myasthenic crisis. The acetylcholine level should not be too low and it should not be too high, because we are going to have problems. Now, you administer anticholinesterase medication as prescribed. Instruct your client to avoid any form of stress, infection, fatigue, over-the-counter medications. Then education on eating. Larger meals should be taken in the morning and smaller meal later in the day. This patient usually have strength in the morning. They usually have strength in the morning. So you don't want to give them larger meals when they are not having enough strength. Then you schedule their meal to 30 minutes to 1 hour after taking their medication. You want to give them thickened liquids because of the swallowing issue they have. Then you tell them to take their food bit by bit. Soft food should be given to them. They should perform most of their activities in the morning. Then many medications are known to exacerbate multiple sclerosis. Myasthenia gravis, sorry. So these medications, you tell them to avoid such medication. Then you instruct your client to wear medical alert bracelets. Then take note that there is no cure for this particular disease condition. There is no cure. Then you watch out for myasthenic and cholinergic crisis. I think I've said that earlier on. Then signs and symptoms of cholinergic crisis will be similar to overstimulation of the parasympathetic nervous system. I think I've said this when we're talking about nervous system. So signs and symptoms that the patient will display when the patient is having cholinergic crisis will be similar to what? The overstimulation of parasympathetic nervous system. Because these cholinergics are found in the what? The parasympathetic nervous system. Patient will come down with muscle weakness, respiratory failure, pulmonary constriction, bradycardia, bronchoconstriction, excessive salivation. We know that cholinergics allows for what? Excess secretion in the body. So there will be what? GI symptoms, bladder incontinence, and so on and so forth. So now let's talk about the treatments. Let's talk about the treatments. I think I've spoken about anticholinesterase. An example of that anticholinesterase is pyridostigmine. So we have heard this before. This is not a new medication, pyridostigmine. Then another thing we can give to this patient is what? Corticosteroids. And why are we giving corticosteroids? We have come to the end of the class. Why are we giving corticosteroids? You can tell me why. Why are we giving this patient corticosteroids? If you're actually following me, you can tell me why we are giving this patient corticosteroid. Please kindly respond. We have about 316 learners in the class. So nobody knows. We are all senior students, so we should know why. No, it's not an antidote to reduce inflammatory process. Okay, we are getting there. Please, more response. I need more response, please. Can't hear you again. Can others hear me? Okay, some say to reduce inflammatory process, to reduce inflammation. Thank you. Then do you also know that corticosteroids suppresses immunity? So corticosteroids also suppresses immunity. And I told you that it is an autoimmune disorder. I told you it's an autoimmune disorder. So corticosteroids will help. Yes. Corticosteroids suppresses immunity. So when you give corticosteroids to a patient with myasthenia gravis, it will help suppress what? Immunity. So that's one of the major reasons why this patient will be given corticosteroids. Yeah. And it's also improved muscle sphincter. Thank you. Okay. Then another thing that can be done for this patient is thymectomy, removal of the thymus gland. Because it is believed, I don't know if it is proven, But it is believed that most of these antibodies are produced by what? By the thymus gland. So it is believed that most of these antibodies are produced by the thymus gland. So sometimes thymectomy can be done. It's a treatment period. Plasmapheresis too can be done. So do you all know the meaning of plasmapheresis? What do we mean by plasmapheresis? Plasma. So the word plasma, you should be able to know. Plasmapheresis. From the word plasma. It's just the removal of antibodies. Yes. So that's another thing that can be done. Removal of antibody from the blood plasma. So then finally, you can give anticholinesterase, which we have spoken about. Any questions so far? Yes, it's performed especially to remove antibodies. Yes, removal of blood plasma. Any questions so far? We have come to the end of the class. Thank God for favorable network today. So we are going to have another class probably on Friday. So we have one more study section to go also. So remove plasma and substitute with a new one. Thank you. More like an exchange. Yes. Well, if thymectomy is done, well, can say the patient will be susceptible to more infection. So that is where your nurse intervention comes in. You have to maintain high level of aseptic technique, educate your patient to avoid any form of infection. So I think you have to weigh the one that is actually weigh your options here. All right, thank you. All right, so I uploaded the final quiz yesterday. So please kindly attempt the quiz. I'm begging you now. If you do not do my CA, you will not write exam. Because it's only the names of students that we present for that we present. Only the name of student that writes CA, continuous assessment, will be allowed to write the exam. Okay. So if your name is not on the CA list, unfortunately, you might not be able to write the exam. Attempt your assignment, attempt your CA. Be present on the day of face-to-face facilitation because you are going to write a test. You are going to write a physical test. And we are going to take, what's it called? We are going to take attendance and it has mark. So, all right. We are going to consider the Muslim brethren. Thank you. Bye. Have a nice day. Thank you.